Welcome to the Healthy, Wealthy, and Smart podcast. Each week, we interview the best and brightest in physical therapy, wellness, and entrepreneurship. We give you cutting-edge information you need to live your best life, healthy, wealthy, and smart. The information in this podcast is for entertainment purposes only and should not be used as personalized medical advice. And now, here's your host, Dr. Karen Litzy.
Hey everybody, welcome back to the podcast. In today's episode, I'm so happy to have on physiotherapist Tom Goom. So Tom has gained the nickname Running Physio after years of combining his passion for physio and love for running to specialize in management of running injury. He's written widely on the topic with over 200 evidence-based articles for his own site, running-physio.com, as well as contributing to the BJSM Blog, Runner's World, and the Telegraph. In 2016, he published a masterclass on proximal hamstring tendinopathy in the Journal of Orthopaedic and Sports Physical Therapy. He presents his running repairs course in the UK, internationally, and online, covering a range of topics from training load management to bone stress injuries, strength and conditioning, and more. So in this podcast, what we decided to do is we decided to tackle a case study. So you'll hear the case study right in the beginning, and then we kind of go through Tom's subjective evaluation, his objective evaluation, and some possible treatments for this patient. Our fictitious patient has gluteal tendinopathy. We reference a couple of different papers. All of those papers can be found over at the podcast website, which is podcast.healthywealthysmart.com. And you one click and we'll take you to all the papers that we're referencing in today's episode. So hopefully you guys get a good idea of how Tom may approach these patients and some ideas for your own patients with gluteal tendinopathy. Enjoy. Hey, Tom, welcome to the podcast. I'm happy to have you on.
Hi, Karen. Thank you very much for having me. I've been looking forward to it.
Yes, I know. We spoke about this when we met in Copenhagen. So we were at Sports Congress in Copenhagen and was at the end of January, beginning of February, where for me, it was really great because you get to meet all these people that you only know via social media, actually in person.
Absolutely. I think that was a highlight for me of the conference. There was the people, it was such a lovely group, wasn't it, that we were there with and chatting to and sharing a dance and a drink with. It was really good. Yeah.
I remember Christina Lee, the physio from Canada, I think she put on Twitter when we had that like massive selfie that Sarah took. She said something to the effect of, I came to Copenhagen with 4 friends and left with like 20 or something like that, which I thought was so sweet. And for all the people listening, like I highly encourage you to go to that conference next year. I think it's a great conference. I mean, what did you think of the overall conference?
I thought it was brilliant. I would definitely echo that. I definitely recommend people to go. And I think it felt the thing that was amazing about it was with the people is it just felt like being amongst old friends, which is strange when they're people you haven't met face to face, but quite quickly it just felt like being amongst old friends, just chatting and and enjoying all the amazing content. But having some people that you can chat with over a beer or two at the end of the evening is always a highlight as well.
Yeah, and I think those conversations at the end of the evening are always the ones that tend to be very meaningful and tend to give you so much energy and potential when you go back to treating your patients or go back to your research. Or I just find that those late night conversations are great.
Absolutely. Providing you can remember any of them the next day.
That's true. That's a good point. And I had like the flu, so I was like in bed super early each night.
Yes.
But I did like the night of the dinner and the gala. I stayed up as late as I could. But
I remember you being up fairly late, I think.
Yeah, I was up late on that one night, but the other nights I was like, nope.
Yeah.
I am sick. I am so sick. Okay, so today we're going to be going over a case study, which I think is a great way for people to learn. So thank you for being open to this format for the podcast for this episode. So this is our case study. We have a 55-year-old woman who runs half and full marathons, but also relies on running to help with mood and mental well-being, which, as we all know, is very common. She presents to physiotherapy with gluteal pain after an increase in training volume and hill running. So that's our case. So now, Tom, let's take it to you. We'll kind of go through the stages of how you would evaluate and maybe some possible treatments. So let's start with the subjective.
Oh, I like to really get the patient's story first and foremost, and to really try and give them a chance to tell it uninterrupted. So I'll often start with, simple questions like, how did this all start? Can you tell me a little bit about what brings you in today? And then give them a chance to tell me as much as they want to, really, without wanting to jump in too much, so they get a chance to really share with me what the important things are to them, how the injuries come about and things. And then once I've heard their side of the story, then I'll try and probe in a little bit more to find out about various different details. Broadly speaking, I'll want to know about their training that's led up to the injury, what their goals are, what they're looking to try and get back to. But also, really, really importantly, I want to know about the impact the injury is having on them, beyond the pain, but what kind of impact is it having on their life and activities that they, that really matter to them.
And so if we're taking this example of this 55-year-old woman who's coming in with gluteal pain, and I'm just going to say, I'm going to make some things up here, add to it. Let's just say her pain is 6 out of 10, and it's actually stopped her from running. So that's the information you're getting from her. My pain it's intense enough that it stopped me from running. It's intense enough that I came to see you, and I'm a little nervous and a little scared of getting back into running because this pain was so intense.
Yeah. So, important, good information to know, obviously the severity and stuff with it. And there's lots of different sort of ways you can approach it, but I might use that as an opportunity to say, well, what do you believe is actually happening then within that area? What do you believe is going on, to see if I can find out a little bit more about her beliefs around the injury. What does she think it is? And often the answer will be, well, I've looked it up online, I've asked Dr. Google, and I think it's trochanteric bursitis, or I think it's a gluteal tendinopathy or something like that. But I'll often then want to know a little bit more about, well, what do you feel is going on in that tendon? And maybe that's when they'll say, well, I've read that you get these micro tears in the tendon if you exercise, and if you keep exercising, it can lead to damage and maybe even a rupture. We can then sort of find out some of the beliefs underlying the pain when they're talking about the pain itself, because then that gives us an opportunity to address some of those beliefs. We're just starting to see that fear of damage is a factor coming up in the research as an issue in tendinopathy. So looking out for that kind of signs that there's fear of damage and maybe avoidance of the activity because of that fear of damage, if that makes sense.
Yeah, absolutely. And then also thinking about what does she feel like her future prognosis is going to be? Does she feel like, well, I need to stop running, and if I stop running, then it's going to affect this, and it's going to affect my life, it's going to affect my relationship. So you have that catastrophic thinking that can kind of sneak in there as well. So how do you parcel out if someone has that sort of catastrophic, if they're catastrophizing the injury?
Well, hopefully, as you ask them about their beliefs around the pain, some of those things will come out. But also there are, other signs really. Sometimes they're going to have an exaggerated pain response. So pain that's kind of out of proportion with load and things that's happening with it. There's also things I would tend to use, like the pain catastrophizing scale that is actually really useful. It actually it's a 13-point questionnaire. Where if you answer each question, and if you score above 30, it shows you have a particularly sort of a negative viewpoint towards your pain. So if they're in the interview, you're kind of thinking they come across as quite fearful, quite negative about the pain, perhaps that seems to be really magnifying the pain, then I might ask them to fill out something like that. So we've got a bit of an objective measure, which then guides your treatment. As if they're scoring very highly there, I want to spend a bit more time actually focusing on the education and addressing that fear than I would want to say spend really exploring the biomechanics. It helps you to prioritize, to know, where do you want to focus your treatment in the early stages.
So now if you're getting into her, as we said, she has an increase in training volume in hill running. How do you transition into finding out what she was doing, what she is doing?
Yeah, I think, this and pain, they're kind of linking together in the assessment. So I think I'd probably start thinking about it on a kind of run by run basis first, like think about sort of the like changes within a run and after a run. And then I'd sort of think a bit broader. So how is your training structure over a typical week? And then I'd start to think a little bit more longer term, how has it changed in the lead up to your pain? So we're kind of getting a good idea about, the training on a kind of small level, a larger level, and over a longer period of time. But also crucially, you're getting an idea how the pain responds to training. Because it's quite, I think, part sometimes of the way people think about pain is, and other things in life, to be fair, is it's a bit black and white.
Mm-hmm.
I have pain or I don't have pain. I run or I don't run. And sometimes that process of exploring how the pain actually behaves can show them it's not actually really an on-off thing. There's a kind of shades of grey involved, if you like. So I would often start by saying, okay, well, you're telling me it's a 6 out of 10 pain when you run. At what point does that kick in? Is that literally the moment you're starting running? Or can you manage a couple of miles before that kicks in, or even a couple of minutes? And then how does it behave if you keep going? Does that pain stay the same? Does it actually get better? Because we know tendon pain can have a warm-up effect where it actually feels bad to start with, and then it gets better as they go. And staying with it, like, is there anything you can do to change it? Does it feel any better if you're running a bit more slowly, or if you adjust your running style a little bit, or if maybe you avoid things like hills if that's provocative? So that all then becomes quite useful information for me to be able to guide that person, because I might find actually there is a distance they can do before the pain kicks in, or yes, the pain kicks in, but actually it gets a bit better if they keep going. So I'd want to know, in detail, how's it all behaving during that run, and then how is it afterwards, and really how's it for about 24 to 48 hours afterwards, because we know with a lot of running injuries, but especially tendons, is that they often react the next day. So that will then help me to see, how is this tendon, how is this person really managing this training they're doing? And if they're getting a big reaction in pain the next day, that's often a telltale sign that they're working too hard, and then we want to adjust the training accordingly.
And is there ever a point at which you're interviewing someone, and we'll get into your objective exam in a second, but is there ever a point where you're working with someone and you are just say to them, stop running?
So yeah, it's very rare for me to actually tell someone to stop. I try and help people make an informed decision, really, rather than say you shouldn't be running right now. But there are situations where I'm more likely to advise someone to take a break from running. What it is generally is this kind of balancing act of risk versus reward. So if you feel that continuing running at the moment is of low risk in terms of flaring up symptoms or in terms of causing other bigger issues, and there's an important reward there in terms of maybe training for a specific event, or in this lady's case, running for her mental well-being, we're more inclined to say, okay, well, let's try and keep some running going. Quite different if you're looking at someone with something like, perhaps with this lady in our mind, we might have as a differential diagnosis a stress fracture, maybe a femoral neck stress fracture, which can present with vague thigh pain and symptoms around the hip. If we genuinely thought it was a femoral neck stress fracture, that's a high risk stress fracture. So the risk levels go up significantly, and in that situation, we're going to say to the patient, really, we do need you to stop impact activity for the moment, because the risk is this could progress to a true fracture. So there's that process of weighing up risk versus reward and discussing it with the patient, and then hopefully they can make a good informed decision. And the reason why I put it like that is because one of my bugbears is when people are told you shouldn't run anymore, and they're often told it in quite stark terms, and they're often not told that it's a short-term thing. And I've known people give up running altogether off the back of advice like that. And I really don't want that to happen. So if we're going to take a break, we always explain why. We always say this is a short-term strategy. This is what we're recommending. But as soon as we can safely get you back, we'll be planning to do so.
Right. And making that, like you said, an informed decision between you and the patient, not just you saying, don't do this. I mean, you have a young child. So how often do you say, don't do this? And then what is he going to do?
Yeah, absolutely.
Probably
Yeah.
going to do it.
It sounds like you've met Woody. It sounds like you've met him.
I have not, but I've met a lot of I have a nephew. So I know if I'll be like, Ryan, don't do that. The first thing if I say, Ryan, don't hit your sister, he'll go over and hit his sister. So
Yeah,
it's
absolutely.
always important to kind of get that patient on your side and give them as much information as possible. So I think that's great advice. Now, is there anything else that you're really looking at in your subjective interview?
Well, let's stay with the training for a moment if we can. So we've talked about like how's the pain responding during and after the running, and is there anything we can change? Then I'd want to know, what's your weekly training schedule like? So literally asking this lady, what do you do each day of the week? You know, what running are you doing? How far? How fast? On which surface? You know, what are your rest days? What other sports do you do? Does your work or family life impact on that? You know, maybe she on one of the days of the week she looks after her grandchildren or something like that, and she's carrying them around on one hip, and that aggravates her pain. So I want to get a good idea of, you know, we call it with athletes a microcycle, like your typical week. So we can look again, you know, what can we adjust here to keep this lady doing the things she wants to do, but to bring it down a notch or two to a manageable level. You know, is it about popping in an extra rest day here and there, or just looking at that training structure and saying, okay, you're doing a little bit too much of the hill running here, or you're actually, you've got quite a few sessions back to back that, you know, tendons don't tend to do so well with back to back training days. So looking for all those little things that we can adjust to keep the person running, but without actually having to stop altogether. And that's where I think the weekly schedule is particularly useful. And then going beyond that to the longer training period, it's, you know, asking, well, what changed in the lead up to your hip pain? You know, what were you doing differently? And seeing then, you know, perhaps if she's on Strava or one of the, you know, Garmin Connect or any of the other apps, or maybe she keeps a little training log, we can have a look and see, you know, has her training volume dramatically increased in the lead up to the pain? Has she increased the intensity of the hill running? Because that helps us to establish, you know, causes, and helps us to stop making the same mistake again in future.
Mm-hmm. Right. So it's kind of like a la Tim Gabbett, you know, getting what is their chronic workload, and they have any acute spikes that maybe could have contributed to their symptoms.
Absolutely. And Tim Gabbett's work is fantastic. And that is very much along that kind of idea, that load management, because we know load is an important part of the development of tendon pain. So I think we need, in a nutshell, to know about how they've loaded. I think, you know, that's it. And if we know their goals as well, we know how they've loaded, and we know how much we're going to have to get them loading in their training in the future. So that can help us inform the rehab.
Right. And all of this is going kind of into your head, and you're thinking about some differential diagnoses right away, correct?
Yeah, I think the thing is with this, we're assuming this lady has a clear gluteal tendinopathy. Of course, we know in real life it's not often as clear as that. We would have differential diagnosis coming into our mind, but I think generally with runners, regardless of the pathology, I think we want to know their training history and their goals, because that, you know, they're going to be important, I think, you know, in their rehab and in stopping them from repeating the same sort of training problems again.
Yeah, absolutely. Okay, so we've gone through a pretty good subjective exam. We know what she's feeling. We've got her mental state-ish. You know, her training schedule, because no one really divulges that information on day one.
No. I mean, I suppose with any of the things we would maybe ask it a little bit more about the mood and the mental health, and that would come out when we ask, you know, what impact is this injury having on your life? People will often say, well, you know, I run because it helps me manage my stress, my anxiety, my depression. So actually, I am struggling a little bit at the moment because I don't have that coping strategy, which then, you know, might lead you down other avenues, perhaps talking about other types of coping strategies, you know, relaxation or mindfulness, or actually in clinic, we work with a number of counsellors. So we would often say, well, you know, if this is having an impact on you, come and see one of my colleagues and they'll help. You know, they usually do a kind of 15-minute sort of free assessment to see if there's something they can help with, and then go on to, maybe help them out and find other coping strategies so they're not so reliant on their sport in the future.
Yeah, and I think that's amazing that you have access to that in your clinic. Now, let's move on now to your objective examination. So you've gotten all this information from the patient, this powerful information. How do you then go about evaluating your runners?
Well, I have a sneaky peek at their walking as they come down the corridor to the clinic room. I always try and do that when they're not aware that I'm watching them. So I want to see, can they actually walk comfortably? Are they, if they're limping into the clinic room, it's probably unlikely they're going to be comfortable going out for a run later. So I will have a look at their walking. I'll look at some of the simple stuff often first, like single leg balance and single leg squat control, which is quite important in this population because we know that often they struggle with control around the pelvis. So particularly looking to see, can they prevent contralateral pelvic drop happening when they're balancing on one leg. And actually, if you hold that single leg balance test for around about 30 seconds, it'll often be provocative for pain. So it can also be part of this sort of diagnostic process because it's provocative for pain in gluteal tendinopathy. And then I would look at maybe single leg squat control as well, but thinking more like the kind of mini squat that would replicate the kind of loading part of running. So not your traditional kind of sitting back into it squat that you would do, but looking to see how they can control a single leg dip. And again, looking to see, pelvic control, femur control, those things that we know are going to be relevant in gluteal tendinopathy, because if you're getting lots of pelvic drop and you're getting lots of hip abduction, it's going to take the tendon into potentially a provocative compressive position. Mm-hmm. So I'd look at those kind of basic control aspects. They help guide the rehab as well, because if you can't balance on one leg for more than a few seconds, it's unlikely you're going to go off and do really high level rehab stuff. You might need to get that controlling first. And then there's kind of common areas I would look at that I think might feed into that. So things like ankle range, ankle dorsiflexion range. If I've seen one or two cases with runners where they're actually really quite restricted in their dorsiflexion on their symptomatic side, and it affects their movement, and they actually move into a bit more hip adduction to compensate for it during things like the single leg squat. So you may find sometimes things further down the kinetic chain could be a piece of the puzzle. So I would routinely look at ankle dorsiflexion in runners and see if that might be a factor. And then we go on to assessing the surrounding area. I think it's important to look at lumbar spine range of movement, because the lumbar spine and hip are intimately linked. Look at hip range of movement itself, including extension, which sometimes gets left off but can be restricted. And then assessing the key muscles that are going to be involved in managing load. Is gluteal load is highest actually in the stance phase of running when we're absorbing load. Mm-hmm. And that's when the muscles like the quads and the calf are very active in absorbing load. So you might include somewhere in their assessment, some assessment of quad strength, of calf strength, as well as gluteal strength. And probably already include some assessment of a hamstring as well. So we get a really good overview of where their strengths and weaknesses are, and then where we can kind of target the rehab.
And how are you assessing strength in the clinic?
I use a number of different techniques. With glute med, what I've leaned towards recently is using a handheld dynamometer and assessing them isometrically with that, mm-hmm. And then comparing left and right. And sometimes we're seeing really significant differences with that. So sometimes people with literally 25% of the strength on their symptomatic side versus their good side. But I would consider, your single leg stand and single leg squat as also assessments of glutes function. They're looking at how the glutes actually manage the function of control. So I think a combination of assessing the strength and assessing the control part of the glutes is quite useful. With hamstrings, I do a really simple single leg bridge to fatigue test as a way of testing the posterior chain. We count reps, left versus right. I do a similar thing with the calf. I do calf raises to fatigue on the edge of a step and compare left and right. With the quads, it depends on the patient. I might do single leg rise test, which is basically repeated sit to stands on one leg, again comparing reps left and right. Or I might go for something like a leg press 10 rep max or a leg extension 10 rep max. Mm-hmm. But these would all be tweaked to suit the patient. Some patients as we see in the recent research in gluteal tendinopathy, are actually really going to be quite disabled by the condition, and they're not going to be able to do, single leg bridges, single leg rise session. You might have to go a lot more simple with those tests. And other athletes we see, I saw one lady with a gluteal tendinopathy who was doing a 96-mile ultra marathon and actually had 3 or 4 PT sessions with a personal trainer in the gym every week. So we weren't identifying major differences left and right just with the reps to fatigue testing with her. So there we had to load her up and look at sort of 10 repetition max testing and things in the gym to actually identify much of a difference left and right. So it always has to be tweaked to suit the individual in front of you, I think.
Yeah, absolutely. And I think that's really great advice. And thank you for sharing the ways that you assess strength, because I think everybody has their own little ways of doing that. And I'm happy that you shared. So so you're looking at balance, you're looking at control of motion, you're looking at strength. What else might you be looking at? Will you get them on a treadmill? Will you watch them run? Obviously, depending on the severity of the pain, but.
Yeah, I think quite a lot of this assessment I find will unfold over 2 or 3 sessions sometimes.
Mm-hmm.
I think the challenge is there is so much we can talk about with each patient that sometimes especially if they're particularly a particularly tough time with an injury, you might find some sessions you just about get the subjective done with the patient. So I think it depends on sort of how it unfolds, but typically it would be probably session 3 or 4 in these patients where I might actually get them on the treadmill and have a look at them running. Because although the gait analysis and retraining is valuable, there still isn't really any evidence in people with gluteal tendinopathy that it changes pain. So I'd want the kind of key stuff in there first. I'd want to get the training at the right level. I'd want to look at the impact it's having, look at their kind of their strength and conditioning, their beliefs around pain, spend a few sessions getting a good rehab program in place. And then maybe session 3 or 4 when the symptoms are a little bit less irritable. If this lady's at a 6 out of 10 when she's seeing us, then I might get her on the treadmill or perhaps even do an overground assessment depending on where she does most of her running, really.
And what are you assessing when you're looking at running gait in people with a gluteal tendinopathy?
Well, every assessment I would tend to do a kind of top to toe approach because I find as soon as you focus on one area, you kind of miss other things. But there would be certain things that I might look out for that I suspect would increase the load perhaps on the glutes. So overstriding would be one. So where people tend to land out a long way in front of their body, that is likely to increase the load on a number of structures, including the hip and knee. So that would be something to look for. Sometimes runners will be quite narrow in their running gait, and often that will be accompanied with an increase in hip adduction. So then when they're loading the hip during that stance phase of running, they're loading it in a position of adduction, which we know is quite provocative for the gluteal tendon. So that would certainly be something I'd look for. Also in stance phase, whether they have contralateral pelvic drop, that can go hand in hand with increased hip adduction. So we're having this reasoning process, what in this running gait pattern could increase the load on the glutes and gluteal tendon, and then what can we do about it? Final sort of factor might be perhaps trunk position. Are they really flexed at the trunk? Because increased trunk flexion, particularly if it's coupled with increased hip adduction, can increase gluteal load as well. So they'd all be things I'd look out for. And then we might experiment and try a few things to see if we can change that movement pattern a little bit. It's fine tuning, really. We don't want to make big changes, but then see if that has an influence on their symptoms.
Got it. And not to get too into the weeds here, but are you videoing your patients and then watching this in slow motion? Do you have some sort of video capture? Or do they have wearables on, or
most of the time I would be videoing them on a handheld device, either I use a big one of the larger tablets because it's got a good frame rate and you can really see it on the screen, or even some of the smaller smartphones these days have got high frame rates, and I often use an app, something like HUDLO technique I use quite a bit, because that allows you to actually look at it in slow motion, and And because I think you do need to really. I think it's almost impossible to sort of eyeball someone's running gait and assume, that you can make good, reliable assessments on it. So yeah, absolutely. I would video it and I would look at that in slow motion, and that would hopefully allow me to identify some of those factors.
Cool. And what's the name of the app again that you just said?
It's HUDLO Technique. It's HUDL.
Oh, HUDLO. Okay.
HUDLO,
Oh, yeah, I know that. Yes.
Yeah. It used to be Uber Sense or something, but I think they had to change it because of Uber.
Because of Uber, yeah. Yes,
I think so,
okay.
yeah.
I think you're right. Yeah, that is all. It's all coming back to me. I think I have it on my phone. I sometimes use Coach's Eye, but I feel like it's kind of the same thing.
Yeah, it's just personal preference, really.
Yeah, absolutely.
And then, I mean, if you're looking at, what could reduce the stress on the glutes with gait changes, in theory, an increase in step rate can reduce the stress on the glutes, because the glutes actually work quite hard. The peak load on glute needs about 4 times body weight, and that is during the stance phase of running. And there is some research that increasing the step rate can reduce that peak load a little bit, and would usually reduce an overstride. So if they're overstriding, particularly if they've got a low step rate, it would be reasonable to try increasing the step rate by a little bit. Typically, I start at about 5% and see how they respond and go from there.
Okay.
Or if they are very narrow and they have quite a lot of hip adduction, using a cue like don't let the knees touch. Often that simple cue will get them to come slightly wider between the knees to reduce the hip adduction, because really we do want these changes to be subtle. If we make a big change, it often irritates something else, because we might be offloading or reducing the load on the glutes, but probably at the downside of making something else work a bit harder.
Yeah, no, and that makes a lot of sense. And I like that external cueing there versus telling the patient, having them look down and say, don't let the knees touch, is a lot better than saying, try and keep your knee straight forward.
Yeah. I mean, the step rate's great because that's a purely external cue, because they're just running to a metronome.
Yeah.
I think technically the don't let the knees touch one, I suppose technically it probably is an internal cue, but it's simple enough that people tend to be able to get it. I think if you're going to use an internal cue that focuses on movement, I think it needs to be quite simple.
Yeah.
You're totally right. I mean, if you're saying, right, point your knees ahead, keep your pelvis level, squeeze your glutes. I mean,
what?
And also run.
And then run.
Yeah. It's just too much, and it kind of can suck the joy out of running a bit if you're spending the whole time thinking about a million different things. Yeah.
Can you imagine?
Absolutely.
I have to make sure that when my foot strikes, it strikes this way, and to make sure my knee does keep my knee forward and don't let my pelvis drop. And I mean, you just be thinking the whole time.
Absolutely.
Drive yourself crazy.
And I think, again, it comes down to, communication. And you imagine if you word this gait assessment in the wrong way with a patient with quite a negative view towards their pain, perhaps a little bit of loss of confidence in their body already, you could make it worse. So if you're telling this patient, and I've heard people told this, you're not built for running, or, oh gosh, I've looked at your running gait and you're all over the shop. Like, that's really, I really would recommend not doing that. So, I think whatever we choose to recommend in terms of, our gait or our strengthening, we just try and deliver it in a positive way, highlight the good things, this part of your running gait was really good. This was good. If we could fine tune this a little bit and make it a bit more comfortable, that is much, much more preferable to, well, you're not built for running and of course you're going to get pain.
Terrible. Yeah.
Absolutely.
Terrible. Especially if that person does this to kind of reduce their stress and anxiety with the rest of their life, you're not doing them any favors there. Now, let's talk about, so we've talked about kind of your evaluation and things like that. And I think you already gave us a little bit of some advice on how you would treat them by modifying their running gait. But what else would be potentially included in a full rehab program for this 55-year-old woman with gluteal tendinopathy? So
we definitely would be making some training changes to try and bring her training to a level that doesn't cause lasting irritation. Hopefully we'll be able to keep some running going, because we know it's important for her in terms of her mood and mental well-being. but we could be taking hills out if that's really provocative, reducing the distance a little bit, maybe replacing some of the more provocative sessions with some cross training if that's comfortable. So that's definitely a big part of this. And I think if we don't make those training changes, if they just keep doing what's aggravating it, it's quite hard to get the other parts of the rehab to really work. So that would definitely come in there, alongside some good education, good positive explanation of why things hurt, and in a way that actually allows you to go on to the rehab. We were chatting a bit before, weren't we? If someone believes that they're damaged and the exercise is going to damage that area, and your solution as a physio is exercise, it's really unlikely they're going to do it. So we've got to try and reframe it in a positive light that says, tendons are actually pretty robust. They're really strong structures. They like to be loaded and exercised. And I often say they're a bit like a muscle. We know if you work a muscle, it gets stronger and it gets bigger. And a tendon can do the same thing. It just takes a little bit longer. And we just have to be a little bit more careful about finding the right level of exercise. And if we can find the right level, then we can build you up. So, that then helps us to say, okay, well, let's find the right level with your training, and let's find the right level with your rehab. And then let's build you back up to whatever your goal is.
And do you find that helps with adherence of the program as well? Because you can give all of the advice in the world, but if the person doesn't adhere to it, it's kind of doesn't matter.
Yeah.
So do you find that if you're giving explanations like the one you just gave, that your patients tend to have a greater adherence? Or if you're working with runners, they want to get better, they want to get back to it, so they're going to be more compliant? I mean, there's a lot of different ways to look at this.
Yeah, I'm very fortunate because I think runners are generally very motivated. But I would say, in my experience and also from some of the research, I would say that yes, if you give a more positive explanation like that, they're more likely to do the exercises and things, definitely. But I do think some of it's influenced by their expectations. If they've come in expecting a fix and you're not offering a fix, you're offering them solutions, then that can be difficult to get them on board because you're not quite delivering on their expectations. So it's good. You've got to notice that early on and address it, talk to them about it. But yeah, I think a good explanation. I mean, think about it. None of us would just, if you just gave me a sheet of exercises and pointed me to the door, we wouldn't do them unless we knew why, unless we knew the benefits, unless we knew how it linked to what we wanted to actually get in terms of our goals.
Yeah, totally. And as far as expectations, are you also trying to give general timeline expectations to your patient as best that you can, given the research and your experience?
Yeah, I do try to, but I'm quite cautious with it. I'll often say to people, these things tend to get better, but it is a bit difficult to predict the timescale. And, so we'll say to them, do allow it time to change. And we do have some research now that gives us some idea. I'm sure a lot of your listeners will have read the LEAP trial by Mellor et al. That came out in May. Brilliant trial in gluteal tendinopathy, where they were getting quite positive changes, about an 80% success rate at about 8 weeks. Mm-hmm. So I think that's quite useful to say, we can say, well, from the research, actually quite a few people are going to see some significant change at around about the 8-week mark. So it gives them a ballpark figure, but I'll often, make a little caveat with that and say, well, but some people will be quicker, some people are a bit slower, but hopefully you'll notice this is gradually building towards, where you want to be.
Yeah, and I think that's important to even give that 8-week mark, because I think a lot of people feel like if they're coming to physical therapy, like you said, they're looking for the fix, they want to be fixed quickly. And sometimes people might have like an unrealistic expectation, like it's been 2 weeks. Why don't I feel 100%? So giving people some realistic timeframes based on the literature, I think, can go a long way.
Absolutely. And expectations are important. Expect flare-ups. That's also quite important because we've told them we need to find the right level with exercise, but that takes a bit of time. So if they know session 1 or even session 2 that probably at some point they're going to do a bit much and things are going to be sore for a day or so, but it's fine. We'll help them manage it. It just means they've worked a bit hard. It won't harm anything. Then it's less scary when it happens. They don't feel they're back to square one. They don't stop all their training because they've had a flare in their symptoms. So yeah, I think expectations are quite important, really.
Yeah, and I agree. I think it's important that a flare up doesn't mean a freak out.
Absolutely, yeah. That's a nice way of putting it, actually.
because I know from my own experience, when I would have flare-ups of neck pain, I would freak out. And it just was not helping my cause at all. So now if I have a flare-up, I just go to the gym and try and keep moving. And it's a much better way of being than like laying in bed for the day.
Absolutely. Absolutely. I think it's quite hard. It depends on who you are, but I think quite a few of us, when we have a flare up in pain or actually a flare up in like stress or anxiety and things, it's difficult to be objective. And it's quite easy actually to slip into a habit of maybe ruminating on it and really getting worried about it. And, you know, I encourage patients to actually have, I call it a pause pack. And that is, you know, literally to write down a little bit of a plan for what they can do during a flare-up of either pain or of like mental distress, so that they know, okay, well, when I'm struggling, I've got my pause pack to refer to. And it is useful to have it written down. It literally exercises that help, you know, things to do that are positive, relaxation, mindfulness, trying to stay active, you know, what type of simple pain relief works for them, whether it might even be just a hot bath, a bit of ice, like you said, staying active. You know, if you can get people to have that in place, particularly if they're a patient that's had their problem a while, then that can really help reduce the worry of a flare-up. And actually, what I'm finding is often people don't end up feeling they need the pause back because they've got it. They don't feel they need it. They kind of feel like they're in control. So it's sort of something to fall back on there that, you know, helps them if they're having a particularly tough time.
Yeah, no, I love that. And it's a pause pack. I feel like your accent's getting to me. I'm like, what's
pause
he saying?
Yeah,
like
pause. Pause is in
P-A-U-S-E?
like the pause button on the telly. And
Okay.
I call it that because it is important to kind of like pause for a minute,
I
take
love
stock
it.
of where you are, and, you know, and then you can kind of hopefully have all the kind of key stuff written down in there, really.
Yeah, no, I love that. I think that's a great idea. And I'm going to start doing that with my patients and with myself probably.
Oh, cool.
I think that's a great idea. And I think it can also help with that calming of the nerves a little bit. And also, like you said, making sure that you tell the patient you may have a flare up. And if you do, it's not uncommon.
Yeah.
Because
absolutely.
when you have a flare up, especially if you have like a gluteal tendinopathy, because that hurts.
Oh yeah, absolutely.
I mean, that is super painful. And if you have a flare up, you're like, oh no, here we go again. What am I going to do? I'm not going to be, this is going to throw me off for another 8 to 12 weeks or something like that. So being able to at least understand that it's a possibility of happening goes a long way.
I think as well, sometimes sense of humor can help us in these situations. One of my patients, she had a flare up in her gluteal tendinopathy, and she said, "I'm fine. I've just got a very angry buttock."
Yeah,
and I thought that was a particularly good way of putting it. Just got an angry buttock.
Yeah,
fair enough. You know, and she could laugh at it, and she, you know, it wasn't so much of an issue. She knew she could deal with it. So sometimes, you know, a bit of sense of humor helps us through the hard parts. I think.
I think that can be a good coping strategy versus kind of ruminating in your head about all the things that could go wrong now that you've got this pain, now that this pain, quote unquote, is back.
Yes, absolutely. So the thing is, obviously we talked lots here, but we know the rehab, we haven't talked about the rehab yet, but that's obviously a big part of it. And staying with that LEAP trial, there were lots of different great exercises in that LEAP trial, which is open access. So it's well worth people having a look. That they did this progressive loading to strengthen up the glutes and the glutes tendon. With runners, sometimes I find I would need to take them to perhaps a higher level than you would with someone who's perhaps coming in. You know, they're quite deconditioned. Maybe their goal is to be walking pain-free as opposed to running pain-free. So with the runners, I'll often look at, you know, the strength, the control, and the range of movement. So I would want to build that you know, foundation of control with things like single leg stand and single leg squat. Then perhaps taking that on to step ups and lunge movements or squat movements to get the control of those movements to try and you know, improve how they move around the hip and the pelvis. So I would include some control exercises in there. If there is a loss of range of movement at the hip or the back, then I would, or down the chain and the ankle perhaps, then I would usually include some range of movement stuff in there too, just to try and restore that normal range. If you think, for example, if you've got a loss of hip extension, it's difficult for you to propel effectively in running because you need a good sort of 5 to 10 degrees of hip extension during propulsion. So trying to restore the range for function. And then strength-wise, typically I do want to include at least 2 or 3 exercises for glute med. And they usually will need to be out of adduction positions initially. And I might need to start with them isometrically. So with this lady, if she's quite irritable, she's 6 out of 10 pain, I might start with something really simple like lying on her side, but with the painful leg uppermost, supported on pillows. So perhaps it's just in slight abduction, and just getting her to lift the weight of the leg off the pillow. So she's just doing a little bit of hip abduction, but not from an adducted position, and maybe starting with quite short duration holds, 10 or 15 seconds, and gradually trying to increase the length of time she's holding that for. I might include in there perhaps some isometric hip hitches, which was used in the Globe trial. And quite nice part of that Globe trial is that they did some EMG studies on postmenopausal women, and they actually found that the hip hitch actually really does recruit the glute med quite successfully. So that was part of the reason why the hip hitch formed quite a strong part of their rehab program in there. So you can see it's going to work. The glutes maybe help pelvic control too. So we could have a little bit of abduction work, a little bit of hip hitching early on, isometrically to help activate the glutes, calm some of the pain down, and then start building in, as things get better, some of the single leg control work, start taking that to more dynamic glute med exercises, again probably starting out of adducted positions, building up the strength, and then perhaps towards the end of the rehab exposing them to deeper positions of hip flexion, deeper positions of adduction if they need it for function. And you see in some sports, look at things like skating and curling and football and team sports, they do end up loading in adductive positions. So we may need to actually load them into that in their rehab, to prepare them for it.
And are you also adding in any plyometric work, jumping, that kind of stuff?
Yeah, potentially. I'd often want to achieve our strength goals with the glutes, often strengthen the rest of the kinetic chain. As we said, the quads and the calf. Again, they did that in the Globe trial. But plyometric stuff I would include right at the end, because the downside of plyometric stuff is it's often quite provocative. And if you're adding it onto running, which is also a plyometric activity, it can be enough to tip people over into a flare up. So I often find a lot of people do quite well with the training load management, the education and simple strength work. And then if they're at a high level with their sport, maybe they're a jumping athlete, you're a volleyball player, a basketball player, a high jump, long jump, then yeah, absolutely, I want to bring in some plyometric stuff. But for quite a lot of people, once you've got them stronger, you've got the training at the right level, you've got the lifestyle stuff on board, they're often doing quite well, and they're often back to the kind of training they want to do. So you may not feel they need to go that step further.
And so you're really looking at what in this case, we've got a runner, but I'm glad that you brought up things like football, or where people have to get down into a lower stance. So if you're like a tackle in football, you're down in a flexed and oftentimes adducted position.
Absolutely, yeah, absolutely. Hockey's another one. I mean, look at a lot of hockey players in quite sort of flex strength positions and things. So
like the goalie.
Absolutely. But also, I think as well, there's an aspect of this that it's just starting to come to the fore. Like we've got evidence in people like Sean McAuliffe. We've got this brilliant work by Plinsinger et al. Recently. We've got smaller stuff like Green's work, which is a master's thesis, showing the kind of the fear, the psychological aspect to tendon pain. And yet at the same time, we are also teaching people avoidance, which doesn't go hand in hand with that very well. So we're often telling people this is compressing the tissue and therefore it needs to be avoided. So I think that we've got to try and marry up those concepts together. There's good evidence from the LEAP and Globe trials that education to reduce compression can help reduce pain. But I think maybe that needs to be delivered in a way that allows you to make those activities normal and allows you to bring people back into normal activities when they're comfortable to. So I don't use the word compression too much anymore with tendons. I would just tend to say, well, if you add up the hip, if you sit with your legs crossed, it just irritates a bit at the moment. So for the moment, let's try and reduce those until it calms down. But long term, I want you to be able to sit however you like to sit. You know, I want you to be able to do these things. They're normal, but just for the moment, let's reduce those to help it calm down. So we're not leading to avoidance, because I am seeing some patients with tendon pain that are avoiding really quite, simple things like avoiding sitting altogether because they're terrified. I've treated particularly proximal hamstring tendon. I know patients that won't go out for dinner because they can't find anywhere that they're happy to sit. And that's really sad. And as we talk about impact, that's the real life impact for that patient. They've stopped socializing because they're frightened that sitting to have dinner with friends will damage the tendon. So that's where we've got to be a little bit careful we don't oversell those messages. And actually, in that case, you could almost argue that message has almost led to, disabled that patient in
disability.
A way. Yeah, because it was probably delivered overly, you mustn't sit, as opposed to saying, well, most of us sit for 6 to 7 hours a day. It's fine. Just cut it down for a little bit until things are a bit more comfortable.
Yeah. So it sounds like what you're saying is when you're delivering these messages, to not deliver it in an absolutist way, but to say, hey, listen, this is what's happening with you right now. So let's make some modifications for now. And as you start to feel better, perhaps we can, sprinkle these things back in until you can do whatever you want to do with your body.
Absolutely. Yeah, absolutely. And that's, they'll know as well that these things can be a bit provocative. So when they do too much of it in the future, okay, maybe that's what's triggered the flare up. And we had a good case with that this week, a really lovely patient who I haven't seen for about 8 or 9 months. He's a proximal hamstring tendinopathy patient, because he's not had any symptoms. But he went off and did a really long drive, 5 or 6 hours up north, and then spent the weekend cycling, doing loads and loads of cycling, and then did the same 5 or 6 hours drive back.
Right.
And that flared up his symptoms because it was 3 days of sitting consecutively for 5 or 6 hours. Yeah. So because we've said to him, well, it might stir up the tendon a little bit, he knows. He's come back and he said, well, I know I've got to just calm it down a little bit, I've got to reduce the sitting for a bit. But I'm pleased in a way that he's done it, that it hasn't stopped him. He's still wanted to go up to Manchester and drive up north and do the cycling, do the stuff that he wanted to do. And then he'll just manage the symptoms afterwards. It's not led to avoidance. He's just perhaps pushed it a little bit too far, if that makes sense. So there's a contrast there between this gentleman who's still able to do the things he wants to do and someone who has actually led them to stopping quite important stuff as a result of it. So it's trying to find some kind of sensible middle ground, I think.
Yeah, like you said, there's so many areas of gray between a yes and a no and a do and a don't.
Yes,
that
absolutely.
As a therapist, we have to be cognizant of that with our patient and how that affects our patient's psyche and their beliefs around their injury and pain and recovery. And I think that's where you have all the research to guide you, but that's sort of the art of the therapy, isn't it?
Absolutely. Yeah, there's definitely, I'm a firm believer in that there is certainly there's an art to it as well as a science. As people like Christian Barton would say, I agree with that. There is that mixture of the two.
Yeah, for sure. Okay, so is there anything else you want to add about this particular patient? We've gone through some evaluation, some treatment, how we talk to them, how we include their thoughts, beliefs, and did we miss anything?
That's a good question, because I think the one area that perhaps does bear talking about is some of the intrinsic factors that affect tendon health. And when you look at this lady, she's a 55-year-old lady, and when you look at the population for like the LEAP trial, I believe about 80% of them were ladies in their 50s. And we think that's really important for gluteal tendinopathy because hormonal changes around the menopause affect the tendon health and how well it can manage load. So I think that would be a factor to consider, and to consider with all tendinopathies, is there anything else here that can influence how well this tendon is managing load, and how well it'll adapt to load. So if we think that perhaps there's hormonal change leading up to the menopause or after the menopause, and that's influencing the tendon, what it often means is our rehab needs to progress a little bit more slowly, because the tendon won't adapt so readily to it. So we might be a little bit slower with our rehab progression, a little bit slower with our training progression in terms of getting her back to her goals. Perhaps a little bit more careful to change sort of one thing at a time in that process, not to up the load, up the running all at once, and then find that we're having flare up. But there is research being done at the moment. Ganderton et al. Who did the Globe trial, that trial, as I understand it, is part of a bigger ongoing trial looking to see whether taking hormone replacement therapy affects outcomes in gluteal tendinopathy. So it'd be interesting to see. If it does, it may then give another option for women with gluteal tendinopathy.
Yeah, so much to think about.
When
this person's in front of you, I think you gave a really great overview of how we as therapists can kind of think about these patients when they walk in our door. And so thanks for that. Now,
thank you. It's been good to chat.
Yeah.
I mean, there's one thing I will mention, Karen, if it's all right.
Yeah,
is that,
absolutely.
We can give a link to this if you like, because there's so much to think about with tendons. So we developed this tendon health questionnaire a year or so back. It's actually a team effort on Twitter, involving lots of people involved in tendon research and treating tendinopathy. So that's it's a one-sheet wonder. So essentially, once you think it is a tendon problem, you ask the patient to fill it out, perhaps between first and second session, and it screens for things like changes around the menopause, like diet, diabetes, certain medications, various other past medical history that can influence tendon health. So it allows you to kind of screen for any of these other things, and helps to make sure that you cover all the bases. But it's also got a question in it about fear of tendon damage, and questions about sleep, stress, and mental health. So it's designed to kind of, allow you to identify areas that you might want to then explore more with the patient.
Awesome. And if you'll send that to me, we'll put it up in the show. We'll put it in the show notes under this episode, along with some of the research that we've been kind of alluding to throughout the program. So for everyone listening, if you go to podcast.healthywealthysmart.com under this episode, which is going to be 356, we'll have all these resources. So you're one click away and you can get them all.
Brilliant.
And now I have one more question that I ask everyone, and I probably should have prefaced this to you ahead of time, and I'm sorry that I didn't. But you
got me nervous now, Karen.
It's really
kind of question is this?
It's an easy one. Don't worry.
Good. Okay.
So, given where you are now in your life and in your work, what advice would you give to yourself as a new graduate straight out of physio school?
Ooh, that's a good question. I think probably I would say, really try and harness your passion for the stuff that you really like, because that's what's really helped me, I think, in my career is when I started to specialize in running injury, because I love running and working with runners and all the things that go with it. That really kind of sparked off the passion to then want to explore it, to want to read the research, to want to know more about it. And I think, if I could have harnessed that earlier on in my career, then, that would have been brilliant. And who knows where I would be today, I think, if I'd have managed to find that sort of, in those first few days of being physio.
Well, I mean, I think you're doing okay. But I think that's great advice. But I think you're doing just fine where you are. I think you're probably exactly where you need to be.
Yes, thank you, Kerry.
That being said, where can people find you?
Come and say hello on Twitter. I'm at Tom Goom. Come and see us on the website. So it's running-physio.com. And we're also on Facebook. We've got a Facebook page, Instagram, all the usual. But I'm most active on Twitter, so that's probably the best place to catch me, really.
And we'll have your website up on our website as well. And you have a newsletter and everything. Well, whatever.
That's right. Yeah, we got a newsletter.
Which is really good. So I encourage people who are listening to this to sign up for it, and we'll have a link to that.
Thank you.
You're welcome. Thank you for coming on and sharing your knowledge with us today. I appreciate it.
Thank you very much. It's been really good fun. It's been good. I feel we could. This is something we could talk about this for hours. I reckon wouldn't be a problem.
No, 100%. But people will probably start to get a little bored. Although I hear the long form. Christian Barton said, if you're going to do a podcast, it either has to be like 15 minutes or less, or long form. Anything, or I think 20 minutes or less. He said anything else in between, people kind of tune out. So I would assume this was more a long form, but it was such great information. So thanks so much. And everyone, thanks so much for tuning in today. And like I said, all the resources will be at podcast.healthywealthysmart.com under this episode 356. So everyone have a great week and stay healthy, wealthy, and smart.
Thank you for listening, and please subscribe to the podcast at podcast.healthywealthysmart.com. And don't forget to follow us on social media.